My loving Sairam to you all. I am extremely grateful to our beloved Swami and Sathya Organization UK to give us yet another opportunity to bring another healthcare webinar on our ongoing series in the centenary year. I am privileged to introduce Dr. Reshma Rakshit, who is a consultant in gastroenterology in the UK. She completed her MBBS in Calcutta in 1997 and moved to UK for further training in 1999. She received her MRCP in 2002, followed by a master's in health service research in 2006. After completing specialist gastroenterology training, she became a consultant in 2009 and has an NHS and private practice in Chelmsford, Essex. Her interests include luminal gastroenterology and neuro-gastroenterology. She also has keen interest in patient education, as she believed it is an important and a key in self-empowered health and well-being. I'm sure, dear listeners, you will definitely be more educated after listening to her talk today, because this is something, a very, very important topic. She has chosen digestive health as her topic today. Thank you.
Good evening. My name's Reshma Rakshit and I'm a consultant gastroenterologist in Chelmsford. Thank you for inviting me to speak at your meeting tonight. I'd like to talk to you about digestive health and perhaps give you some tools to try and improve your own. I'll be available for questions right at the end, so feel free to send them to the moderator. Of course, it's important to note that this is general information. It doesn't replace your doctor or your gastroenterologist. And I'm only talking to you about adult gastroenterology or digestive health. To make things easier, I've divided my talk into 4 sections. We're going to talk a little bit about anatomy or the structure of the digestive tract. And we'll move on to some common conditions like heartburn and irritable bowel syndrome. And I'd then like to talk to you about some commonly misunderstood facts, rather myths, that seem to be perpetuating around. It's important to note this is based on my knowledge and my experience as a gastroenterologist for almost 25 years. And as I mentioned before, we're going to take some questions at the end. So we're going to talk about anatomy first. In my opinion, the digestive tract is the most important one in our body. It's long, complex, has many functions, and gives us one of the main pleasures of life, which is enjoy food. So we start at the mouth, where the food starts being chewed. That starts the process of digestion. We've got what's marked as salivary glands here, which are our 3 glands around our mouth that produce enzymes that break down starch. And then the tongue and the muscles in our throat start moving the food down into what's marked as the esophagus here. This is our food pipe, and it's about 40 centimeters long. The food then moves into the stomach, and the stomach is a large churning and grinding machine. And this keeps mixing the food along, producing acid from its lining to help digest the food further, and then moving it along into our small intestine. Now it takes approximately a couple of hours for the food to leave the stomach and enter the intestine. Within the small intestine, which is marked in the center, the main process of digestion takes place. You can see that you've got the gallbladder and the pancreas, which are two adjunctive organs that secrete bile from the gallbladder and pancreatic enzymes from the pancreas. These move along with the food into the small intestine and helps to digest these specific nutrients. One of the key features of the small intestine are the 3 million bacteria living within us. These bacteria are our friends, and again, they're key to life. You may have all heard about the microbiome, which has been talked about a lot, and in fact, more and more the research is leading to the importance of this microbiome, or the kinds of bacteria we harbor in our gut, which help many processes of life. If there is a dysfunction or a change in the microbiome, it can lead to a lot of ill health. And we'll talk about some of these as we move along the talk today. One of the other amazing facts about the small intestine is that it's 5 meters long. So it has a huge absorptive surface. So if you imagine the small intestine like a long thin balloon, which when it's filled up with food, gas and liquid, moves everything along, and if it doesn't do that properly, it can sit in there, causing some of the common symptoms patients talk about, which is bloating and swelling of the tummy. We then move on to the large intestine, where the liquid waste that comes out of the small intestine enters it, and the liquid waste is moved along, and along the process the lining of the large bowel absorbs water from all of the liquid waste, turning it into solid waste or feces or poo. And then this moves along and gets stored right at the bottom of our large bowel, which is called the rectum. And at the right time, the muscles at the bottom help us evacuate or pass the stools out. One other organ I didn't talk about here is the brain, which is fascinating and linked to the digestive tract in many ways. So you can imagine, even before we start eating, when you go to a restaurant and you smell the food, our brain sends these signals that food's coming to our intestine or our gut, and they start sending signals to the appropriate cells to have all the enzymes secreted. So our gut's prepared to take the food in at the right time. And when we start chewing and swallowing the food, we're ready for it. On the other hand, if someone has a NutriBullet, and there are others in the market, creates all these fantastic smoothies and dunks it all in, we hardly get that time to prepare the gut. And there could be some issues arising as a result of that. And again, this is something I can talk about later. I'm going to talk about some common digestive symptoms, and these include heartburn or indigestion, as a lot of people call it, belching or burping up of gas, bloating, which may include swelling of the tummy area, flatulence, which would mean expelling gas from the bottom end, irritability of the bowel, which when it presents as a syndrome is a significant condition, and I'm going to talk about it later, and constipation, which means inability to open bowels properly. We're now going to talk about heartburn. Heartburn, or gastroesophageal reflux disease, GERD for short, is very common. 25% of the population may suffer with these symptoms at some point. In some people, the symptoms are actually quite mild, but in others it can be quite severe, persistent, and troublesome. Most people describe it as a sensation of discomfort or burning in the middle of the chest, and some others talk about it being like an acid sensation at the back of their throats. Interestingly, heartburn can also present with other symptoms. Chest pain is quite common, and in fact, I've had lots of patients who've had such bad heartburn that they've ended up in A&E thinking they were having a heart attack. I always tell patients to take chest pain seriously. So if it feels significant, you must go to A&E. Some people get a chronic tickly cough because the acid comes up into the back of the throat. This can lead to the acid causing a sore throat because it ends up close to your vocal cord and can cause a hoarse voice. In some people, heartburn manifests as regurgitation, which means an involuntary bringing up of food, which can be solid or liquid, right up into the gullet, into the back of the throat. If heartburn continues for a very long time, it can become complicated. It can cause narrowing of the gullet due to scarring, and that can cause difficulty in swallowing. Some people also experience a lot of hiccuping due to an irritation of a muscle we call the diaphragm between our chest and our tummy. Okay, so what are some common causes of reflux? Well, they occur in conditions like pregnancy, and essentially this is due to an increased pressure on the outside of the stomach from the contents of the abdomen, causing acid to come up the wrong way. The same problem can also occur in overweight or obese individuals. Smoking is a significant risk for heartburn, and we ask patients to stop this. There are certain foods which a lot of people experience causing excess reflux, and these include fried food, fatty foods, excessive caffeine, alcohol, and chocolates. As I mentioned before, the gut is linked to the brain, so we know stress and anxiety increases acid production in the stomach, and therefore this can reflux back up. Certain painkillers like ibuprofen, Nurofen, diclofenac, there are others in the same category. We call them anti-inflammatory painkillers. These can also cause an increase in acid production of the stomach. There are some simple things like large meals. So a lot of people experience this when they've gone out for dinner, eaten a 3 or more course meal, and they get heartburn. This is because the more food that there is in the stomach, the more acid that's produced to digest it. But also a large meal would also cause pressure within the contents of the stomach, and of course you would get reflux. A lot of my patients tell me that after they've eaten, they've got to loosen their bra because it's so tight, and the reason again is the same. There's an excess external pressure on the organ stomach causing the reflux. Exercising is good for all of us, and there is increased evidence that if you take a stroll after your meal, it can reduce your blood sugar levels. However, if you do exercise, vigorous exercise like going to the gym, this will simply increase the movement of food back the wrong way up and cause reflux. So how is heartburn diagnosed? Well, the first is to speak to a doctor, your GP perhaps, and based on your symptoms, they would consider heartburn to be an option or a differential. And in some cases, they would normally use some medication to see if they help, and they would talk to people about their lifestyle. If, however, these interventions don't work or the GP suspects something more significant, they would send you off to have an endoscopy. So endoscopy is a generic term. It means looking inside the body. The specific term is called a gastroscopy or a camera investigation. And this involves passage of a very thin tube, size of my finger, about 1 centimeter in diameter, which is very flexible, which is then inserted through the mouth or through the nose, and it allows someone like me to be able to look inside the gullet and the stomach and be able to diagnose a cause for symptoms. Once someone is diagnosed with heartburn or reflux, there are three main things that can be done. The main focus is on altering lifestyle to help reduce reflux. The second is giving medication or tablets. And the third very rare phenomenon is surgical therapy for this. Within the lifestyle changes, there are several. And these again relate back to the slide I spoke about some of the risk factors for reflux. So weight management is key, eating smaller meals, avoiding high fatty or fried food, excess alcohol with the meals, and avoiding eating late at night. So one of the key things of our digestive tract is that it follows the circadian rhythm, or essentially sunlight, daytime and nighttime. So our gut gets all woken up when it's daytime and wants to go to sleep when the light's gone, the sunlight's gone. So digestion slows down as the day goes along. It's best in the morning and worst at night. And for many of us with our modern day lives, we eat our main food mainly in the evening. And then we're sedentary. And this causes the food to sit there, not being digested, having more and more acid being secreted, and then slouching in front of the TV would cause more pressure on the tummy, which would cause reflux. Therefore, if someone has reflux issues, these would be simple things to do. Avoiding smoking. Once we've eaten, as I mentioned, it takes about a couple of hours for the food to digest. So in this time, if someone ties their shoelaces or starts doing the hoovering or gardening, that can cause reflux of acid up. Tight belts and bras after meals often need to be reduced in patients or people who have these symptoms. One of the key things I talk to people about is bedtime. So lying flat after eating can cause the acid to come back into the mouth. Elevating the head, so making sure the head end is higher than the legs, help in reducing this. And what I found from my experience is that using standard pillows is no good. We tend to slip, or the pillows slip. Having a wedge pillow or raising the head end of the bed, so it's at about 30-degree angle, seems to help. One of the key points again is stress management, and I will come to this over and over again. There are many medication available, many over the counter as well. So you might be familiar with Gaviscon, Rennies, Tums, similar things. These often are antacids, and they provide a little coating on top of the acid pool within the stomach, so that even if there's reflux, the acid is hidden under this film of protection or barrier. These are best taken after meals. And then there are medication like omeprazole or lansoprazole or Nexium. You might all be familiar with these. Often these can be prescribed by GPs or your doctors. These are called proton pump inhibitors. They're very strong and potent medication. And what they do is they shut the acid pumps in your stomach so that even if there's a bit of liquid coming up into the gullet, it's not acidic anymore. A slightly more old-fashioned but useful medication are H2 blockers. One of them is called famotidine, another one's nizatidine, and these can be used in conjunction or separate to the omeprazole medication. Despite having the medication, I have to stress that lifestyle is key, because all of these medications do come with side effects, some less than others. And what you don't want to do is carry on with medication lifelong if simple lifestyle measures can be taken to reduce symptoms. A few people have significant symptoms that are not alleviated by either lifestyle or medication, and a small cohort of patients are then sent off for surgery. It's important to note that surgery, even though it's keyhole nowadays, is not without risks. It can be life-changing for people who have significant reflux or complications of reflux. However, a fair proportion of patients, even after surgery, tend to need the PPIs or omeprazole or lansoprazole like medication. Surgery involves tightening the junction between the gullet and the stomach, so it's tighter and so it prevents the acid from coming up. Reflux is common. It can be managed by lifestyle only. However, if you have persistent symptoms, please do see your doctor. In most cases, medication works very well, and a very small proportion of patients need surgery. We now move on to bloating, which is a very common symptom. Bloating is a sensation of tightness within the tummy area or an increase in size of it. There are many simple causes for it, but it's a common thing I see patients with. Irritable bowel syndrome is a common one, and I'll talk about it in detail later on in this talk. Constipation is another cause of bloating because it means that the intestine isn't emptying properly, which leads to a backup of stool and gas, leading to increase in size and width of the small intestine. You remember my anatomy slide where we said there was 5 meters of small intestine? Can you imagine if it's all filled up with gas? The only place it would have to move, be able to move, would be in front. There are certain food drinks that cause or contribute to bloating. Fizzy drinks is a common one. Chewing gum is another one for 2 reasons. When we chew, we're also swallowing gas or air. And then a lot of sweeteners, a lot of chewing gum have sweeteners rather than real sugar, and this contributes to gas within the gut. Stress keeps coming back as an important point. It leads to dysfunction of the gut, and it can lead to trapping of air or wind. Of course, you'd have abdominal bloating if you were pregnant. I see a lot of women, young women, who come to me with bloating, and one of the key features is that their abdominal muscles have been stretched post-pregnancy. And despite trying very hard, these muscles don't go back to normal because that's the human body. And therefore, food and drink that causes bloating tends to distend their tummy area a lot. This is, of course, distressing, but is not a serious medical issue. One has to be mindful that when we see a patient with bloating, that we take a good history and examination. Tests might be undertaken because worrying things like growths or cancers within the abdominal area can contribute to bloating, ovarian cancer being one important one. I'd like to tell you about a few worrying symptoms that you must go and see your GP about. If you've got vomiting with the bloating, or someone's losing a lot of weight that is unexplained, or there's been a change in bowel habit along with the bloating, or indeed if there's bleeding from the back passage, these need medical attention. I'm now going to move on to irritable bowel syndrome. That's a very common symptom most GPs and gastroenterologists like me see. Irritable bowel syndrome is extremely common worldwide. And in the UK, it's estimated that 1 in 10 of us have IBS. IBS is a condition of the function and sensation of the gut. So when I see a patient for the first time, my job is to try and work out if their symptoms are due to an abnormality in the structure of their gut or not. Most of our tests, including endoscopies, camera investigation scans, etc., look out for structural abnormality. But in irritable bowel syndrome, these are normal. It doesn't mean that the symptoms are in someone's head. It just means that we don't have the tests at this point in time to diagnose this condition. So IBS is a two-organ condition. The current definition is called disordered gut-brain interaction. So DGBI in short. IBS is like faulty wiring in the gut when it's linked to the brain. So if you think back, perhaps, if someone's going to go for a job interview, sometimes they have to go to the toilet a lot. And that's because the stress in the brain is being communicated to the gut and the gut's responding to it. This is a normal human reflex. However, in IBS, this becomes much more exaggerated. In IBS, the symptoms cause significant distress to the patient in emotional, social, and work terms. And this leads to a lot of loss of work and productivity of a country. Symptoms of IBS can be variable. A third of patients have diarrhea, predominant irritable bowel syndrome, which means their IBS manifests as going to the toilet a lot. A third of patients have constipation, predominant irritable bowel syndrome, which means not going to the toilet or straining is part of their IBS. And a third of patients have mixed symptoms. This disorder in bowel movement is associated with belly pain or cramping. This can also be associated with bloating, abdominal gas, flatulence, and distension. Symptoms can be variable within the same patient in the course of their lives. It can be very different between one person and another, and therefore when people come and tell me that Mrs. So-and-so's IBS is like this, why is mine not like that? The answer is we're all different. The wiring within our body is different. The genes within us, between us, is different. So one IBS is not like someone else's IBS. And there can be many triggers. Common ones include food and stress. It's important to understand that irritable bowel syndrome is not a cancer. We don't find ulcers within the gut. Really important that it's not in someone's head. I see a lot of patients who come to me because they've been told they're making up their symptoms, it's in their head. It really is not, and I'll explain to you why. And it's not just a bit of tummy trouble, it's significant. There have been lots of studies done on patients with IBS, and these are some of the real concerns. A lot of my patients are young men working in the city. Some have had to leave their jobs because in the morning they really can't face going on the train, commuting to London without access to a toilet. A lot of my other patients don't go out for fear of losing control of their bowels. Some of my patients have to look for toilets everywhere they go. This has significant impact. So I would always urge people to speak to their physicians, their GPs, and if they don't find a sympathetic one, see another. So what are the common triggers? Food and drink, stress and anxiety, hormonal changes. So a lot of women have worse IBS premenstrually or during their periods. It can also get worse in the menopause. And of course, we know that some people's gut are more sensitive than others. So I'll tell you about an experiment that was done where two groups of people were taken, one with irritable bowel syndrome, the other without, and a little balloon was popped into the bottom, in the rectum, and this was inflated, not to cause pain, but to cause discomfort. In patients who had irritable bowel syndrome, their pain was manifested in their tummy area, not in the bottom. In patients without IBS, they felt the discomfort in the bottom area as expected. They then took this a step further and did MRI scans of the brain in both these groups. And in patients who had irritable bowel syndrome, certain pain areas within the brain, areas that perceive pain, lit up, whereas it didn't in the non-IBS sufferers. So this was like an indirect way of understanding that in irritable bowel syndrome, not only is there a link that's abnormal between the brain and the gut, but there's increased sensitivity of the gut pain sensors. Treatment of IBS is quite complex. It's multifactorial, which means there are many triggers for one patient, which is different from another. I often tell people their IBS is like a jigsaw puzzle. The triggers are these different pieces, and each piece could be sized differently from one person to another. Therefore, it's important for me as a healthcare professional to identify the triggers for each individual patient and try and work on those. Therefore, it's important to explain that there is no cure. Unlike a chest infection, which can be cured by a course of antibiotics, IBS is multifactorial with many triggers. A few common triggers include food, and I send most of my patients off to a dietitian so that the food triggers can be identified. A low FODMAP diet may be something you've heard about. This is but one dietary intervention amongst a whole host of others. This has been very well studied, so it's something that we use commonly. IBS is a dysfunction between the gut and the brain, and therefore just treating the gut won't help. Treating the mind is important too. We know regular exercise is key for gut motility as well as relaxing the brain, and therefore this is something I advise my patients. And of course we use medication to help certain symptoms of IBS. Remember, this is not a cure. I'm now going to move on to constipation. Constipation could be one or more of the following symptoms. So it could be passage of hard stools, not going to the toilet enough, or straining. So what's normal bowel movements? Well, going to the toilet up to 3 times a day or going to the toilet up to 3 times a week is classed as normal. So if someone's going to the toilet less than that, that is constipation. It could also mean that someone might be going to the toilet every day, but they're passing very hard and lumpy stools. And this leads to straining, which means sitting in the toilet, waiting for the stools to come, or really straining to make them happen. Some people tell me that they've gone to the toilet, they've passed their stools, and they feel they haven't emptied enough, so they have to keep going back. And that could also be a symptom of constipation. If the bowels don't clear, it can cause stomach discomfort, pain, or bloating. Remember, you don't have to have all of them to be constipated. Any one of these can be your only symptom. So what could be causing constipation? Well, there are many causes. Simple lifestyle interventions. So if people are not eating enough fiber in their food, it can lead to constipation because the bowel needs fiber to be able to move things along. In the UK, most adults only eat up to 20 grams of fiber a day. Recommendations are up to 30 grams a day. Things like fruits, vegetables, whole grains, pulses have fiber in them. And this is what is lacking in a lot of our diets. However, it's not just the fiber, but it needs enough fluid to kind of help the bowel muscles move stool along. Things that I tell patients to do is to make sure they're drinking enough non-fizzy, non-squash, non-caffeine, just plain water. We don't seem to like it in the UK. Bowel movements is closely linked to our body's movements, which means if we don't exercise, and this doesn't have to be the gym, the bowel's not going to move. So sedentary patients get more constipated than active ones. A common feature I see in my patients is that their lifestyle leads to them ignoring the call to nature. So a lot of teenagers or young people, have busy mornings, having to get ready to get out of the home. And even if they get an urge, they kind of subdue it. And that leads to erratic bowel movements. And the bowel's very clever. It's not always going to listen to your lifestyle. It has its own mind. And like I mentioned before, the bowel's also got circadian rhythm. So the bowels tend to empty in the morning, after meals, and tend not to open in the night. Our lifestyle, however, might be causing these factors to be ignored, and that can lead to erratic defecatory movements, leading to constipation over time. There are certain medications like painkiller medications like codeine that can cause constipation. Iron is another one, and often patients have to take laxatives when they take iron tablets. I have a few patients who work shift patterns, and this can have a really detrimental effect on their bowel movements. There are other people who will only go to the toilet in their own homes and not when they're out at work or at school, and this can also lead to disorders with defecation. Constipation is common, right? But when would you want to see a doctor? If there are sudden new change in your bowel habit that is unexplained by anything particular, please do see your doctor. Or if it remains persistent. If the constipation is associated with bleeding from the bottom, do see a doctor. If it turns out to be hemorrhoids or piles, that's good news, but get it checked out. If someone starts losing unexplained weight loss, along with change in bowel habit, we do worry about bowel cancer. This needs looking into. I'm now going to move on to the second part of my talk, which is looking at some facts or myths. I'm going to start with this. So a lot of people come to me and say, oh, I've gone gluten-free. It's been good for me. Lots of people told me that this is a good thing. They're doing it too. Is this true? Well, it's not. A gluten-free diet came into being because of a condition called celiac disease, which is a gluten allergy. A gluten-free diet is recommended for these patients as a treatment. A gluten-free diet has an excess of certain foods to make up for the lack of wheat, barley, rye. They may taste different. They may have excess fats so that they taste palatable, and therefore it's not for everyone. How about juicing? This is one of my favorites. So I've touched upon it in the beginning. There's a bit of time that's involved between smelling and seeing a food and starting eating. So if we juice, if we have NutriBullet instead of normal meals, then we're bypassing that system. So this highly calorie dense juice, which may contain a lot of nutrients, suddenly enters our small intestine. The small intestine says, ouch, all of this food, I've got to dilute it. So the small intestine keeps pouring in liquid in our small bowel. This causes bloating. This causes pain. And actually, it's not great. If someone's having McDonald's type diet, there are others like that, on a daily basis, yes, juicing is better than that. But eating whole foods is a much better option. So this is a myth. How about this one? Spicy food causes ulcers. The answer is no, it doesn't. Spicy food can cause indigestion, it can cause tummy discomfort, it won't cause ulcers. Ulcers in the stomach are caused by a bacteria called Helicobacter, by painkillers like ibuprofen, Nurofen, by excess stress, and other things, but not the spicy food. So enjoy it. Maybe slightly less at night. And I've alluded to this before. Some people are forced to think that they need to go to the toilet every day. So even if their pattern of opening their bowel is not that they every other day, that's okay. That's within normal range. This one's a difficult one to answer. Sweeteners are non-sugar substances that can be derived artificially, i.e. they've been made in a laboratory, or from natural sources like stevia from a plant. They are good in certain group of people in the short term. So for example, if someone's been diagnosed as pre-diabetic or diabetic and they want to reduce their sugar content, to reduce their blood sugars, sweeteners are a good substitute. However, the studies have not shown any benefit long term. Sweeteners also keep the sweet craving in the human body, and therefore a better option would be to use sugar, reduce it over time, and completely cut it out from your diet. There are side effects of sweeteners as well, especially in the digestive tract. Excessive use of sweeteners can have a laxative effect, can cause bloating, because these substances can't be digested but by our gut bacteria, so they get fermented and produce gas, bloating, loose bowel movements, and other symptoms. There are also concerns about use of certain artificial sweeteners in relationship to cancer and dementia. Studies are there, but they don't all say the same thing, and therefore it's difficult to extricate a definitive answer at this point in time. I would say to you, if in the short term you need to use them, that's great, that's okay, but preferably not in the long term. Finally, probiotics. There are many in the market. They're not all the same. How do you know which one's better than the other? You don't, neither do we. It's because there haven't been many head-to-head studies comparing one to the other. Probiotics contain these bacteria which are purported to change your gut bacteria. However, we really can't change our gut bacteria because it's partly genetically coded. It's partly due to how we were born, how we were raised, how many antibiotics we had, how stressed we are, what kind of foods we've grown up on. So you see, it's really complex area. The only way to really change your gut bacteria is to get rid of your intestine and have it transplanted with someone else's intestine. That's not common, eh? Probiotics, therefore, have a good placebo effect, can be used in certain conditions. So for example, if someone's had antibiotics, they can perhaps have probiotics for the time. And there are a few medical conditions where we actually tell patients to have them. but it's not for everyone. It's an expensive thing to have and with doubtful efficacy. Hence, in my mind, it's not a quick fix for anything. I'm coming to a close now, and I thought we'd just touch upon a simple few measures to help your digestion. These include taking time to eat your meals, knife and fork down between mouthfuls, enjoying what you're eating rather than rushing with it. This is all difficult, I understand, in modern day, but this is key. When we're eating quickly, we're suppressing our brain's switch to help us understand that we've finished eating. So taking time between mouthfuls is important to allow the brain to communicate with the gut to say enough, stop eating. Eating regularly is great because our body is really based on the circadian rhythm. It's got its own clock. Giving it routine helps. Of course, in modern day life, this may not be always possible. Avoid eating a big meal just before going to bed. Give it at least 3 hours for the food to digest before heading into bed. This will give you a comfortable night's sleep. Water is important, can't stress on the fact. 1.5 to 2 liters of non-caffeinated drinks a day is recommended, unless there's other reasons why you would not be allowed to have that amount of fluid. And exercising regularly. So common sense stuff. I'm going to stop there. I think I've overshot my time, and I'll leave this open to questions. Thank you for coming on this journey with me today, and thank you for inviting me to speak to you.
What is ultra-processed food and how does it affect the digestive tract?
Okay, thank you for that question. It's very relevant because everyone's talking about ultra-processed food. So let me just break it down a little bit. So if you take an apple, which is a natural food, and you chop it into small bits at home, that's processing that food, but it's not ultra-processed. If you then make an apple sauce with it at home and add some sugar to it, that's taken it to the next process, which is heating it and adding some sugar. It's still not ultra processed because you find apple, you find a bit of butter, and you find sugar at home. If, however, you go and buy this apple sauce or indeed an apple crumble in the shop, these foods, if you turn around their label and look at the labels, you'll see they're full of stuff that you've never heard. So they're full of emulsifiers, they're additives, there's preservatives, there's artificial colors and tastes added to them. This is ultra-processed food that has been changed from the natural food into substances that are tasty, but they're not natural food. They've been processed, and that's called ultra-processed. Now, ultra-processed foods are being studied a lot, and it has significant effects, especially on the digestive tract. So if you imagine you eat the apple at home, that's great. You're going to eat one apple, you know you're full, that's the end of it. If, however, you eat the apple crumble, you'll be tempted to overeat because it tastes good. And a lot of the food companies now spend a lot of money on research trying to find what makes us reach for that food, what makes it more tempting. So when you overeat, you would naturally then get more reflux, you get bloating, you can get IBS, and so on and so forth. The other worrying thing is that these foods are very low in fiber, and fiber is really important for our gut health. So those are two main ways in which these ultra-processed foods affect our digestive tract.
Thank you, Reshma. That's absolutely wonderful explanation. And I think all of us understood exactly what it meant, what it means to have ultra-processed food. And the second question is, what is the purpose of gut-brain connection?
Thank you for that question. I've used this quite a lot in my talk, haven't I? The gut-brain interaction is a normal human condition. So the gut and the brain talk to each other through the process of nerves and through the process of chemicals that are released in our body. The main function, of course, is digestion. So as I said before, you smell the food or you see it coming, the gut gets ready to accept the food. When we eat enough, the gut then tells our brain, okay, stop. And the brain tells all the enzymes to stop, and the gut stops working in that portion. So for instance, the stomach finishes its job, then it goes to the intestine. So this is really well orchestrated. It's also important for our safety and survival. So, for example, if you suffer with food poisoning, the gut immediately starts expelling these products either by vomiting or by diarrhea. And this is happening because the gut and the brain are talking to each other. We've identified a foreign object and we need to expel it. So that's really, really important. The third way in which this interaction works is by appetite regulation. So our gut hormones tell our brains when we're hungry or when we're full. And the final way I think that this interaction works is in our mood. So we now know if the gut is unhappy, it sends signals of unhappy chemicals to the brain, and the brain feels it. On the other side, if someone is stressed and anxious, that is relayed to the gut, and the gut responds to it. So it's a really important life-affirming interaction between these two organs, which we as humans need to learn how it manifests and how to control.
Thank you, Reshma. The third question is, does digestive health have an influence on our mental health?
Sure. Again, very important question. So we're all hearing about the gut microbiome, which is all these lovely bacteria in our gut, which, when they're not the right kind, they secrete chemicals and neurotransmitters, and it kind of has an impact on our mental health. Lots of research is going on in this field. The second area is if someone has a chronic digestive issue, it has an impact on their mental health. So when I talked about the person not being able to find the toilets, that causes stress and over time can have a significant impact on long-term mental health. In someone with inflammatory bowel disease, there is increased inflammatory chemicals that are being released, and these have been shown to have an adverse effect on our mental health. And there are lots of studies showing that in these patients, we must address their mental health too, along with helping to improve their inflammatory colitis or Crohn's disease with all these fancy medication. But we have to treat both together.
Thank you, Reshma, for this excellent explanation. You already mentioned that probiotics are not a quick fix, and most of us have this in our fridge, and sort of keep taking it with the belief that that's going to really help our gut. Is there any long-term benefits at all in taking these probiotics?
The companies would have us believe that these are great for health and keep buying them long term. The studies don't show that. So if someone has food poisoning, for example, their gut bacteria are all messed up in the short term, taking probiotics is a good idea, no problem. There are some countries in the world where when antibiotics are prescribed, as you know, antibiotics strip your gut of the natural normal bacteria. Probiotics are another good addition in that scenario. There are very few proven indications of using probiotics within gastroenterology. We use them in complex patients who have certain gut infections. This is called Clostridium. We use them in some very small number of patients who have inflammatory bowel disease and they have a condition called pouchitis. And again, in very small instances of patients with colitis or Crohn's. So you can see there's very few indications of long-term probiotic use that's been proven. On the other hand, in most patients, it won't do you harm. If it's a sweet probiotic, it's full of sweeteners or sugar, so be aware of that. If it's for a short term, we normally ask patients to take it for 3 months to see benefit. But really, your question, which is long-term use, we still don't know. I'm sorry.
Thank you, Reshma. Thank you, Reshma. That is clear. And the next question, fibromyalgia, where patients complain of body aches and fatigue, is commonly associated with irritable bowel syndrome. Both groups have subjective symptoms and no definitive diagnostic tests, and more common in women. In patients you see with irritable bowel, do they normally complain of body aches and fatigue as well?
Thank you for raising this issue. It's, as you know, these are both very poorly understood connections. I must say, I don't ask the question. I will from now. I don't ask the question about body pain when I see patients with IBS, but a lot of patients tell me they have already been diagnosed with fibromyalgia or ME. And I see this a commonality between the two because they're more common in women. There is a common element of mental health, anxiety, stress, depression in both of them. There is an abnormality in how the brain is processing pain, which I think occurs in both of these conditions. So I think there are some common ground that makes it commoner to have them together. One doesn't cause the other, so there is no link in that way, but we see them in the same group of patients more commonly. It's to be identified and the patient to be reassured rather than us promising lots of ways in which this can be cured, which, as you know, is not the case.
Thank you, Reshma. And the next question is, will there be any long-term side effects by taking drugs like omeprazole or lansoprazole for hyperacidity or reflux?
So a very common question, I get asked this all the time. So thank you for raising this issue. So in the past, when I remember as a trainee, we used to prescribe these drugs all the time. There has now been some research findings which are making us more careful. So there are certain conditions, say for example, Barrett's esophagus is one, where patients have to take these long term because the benefits outweigh the risks. There are no long-term trials where you've compared one group to another looking forward that gives us a definitive answer that taking these long-term causes problems. There are reports from studies which we call observational studies. We just follow patients up over a long time, or we look back at patients which tell us there is a link with maybe malabsorption of vitamin B12 or iron from the stomach because there's less acid. But patients have to be taking this for a very long time, years, for this to manifest. There are some concerns about osteoporosis or thinning of the bones. Again, these have not been proven through randomized controlled trials, which are the proper trials. There are concerns that it may cause some gut infections. This has been shown. So in patients who are in hospital, who've got diarrhea, we tend to stop using these medications for a small period of time until their infective diarrhea gets better. And there are some reports on effects on the kidney function. So this has also been proven, but it's very small number of patients. So overall, I would say if we've been prescribed these medication, there must be a good reason for it. If you're using it for months and months and months, make contact with your GP. They might contact you already because we're all quite aware of this, just to make sure you're taking it for the right reason. You don't want to stop this suddenly, because if you do, you will get hyperacidity. So when we stop PPI medication, we do it slowly under the guidance of a doctor. So overall, great medication, not best for long-term use.
Thank you, Reshma. And this one more question. Assuming when you have something like IBS, it also brings anxiety and worry with it, especially when it comes to going out or going on long journeys, to name just a few things. Do you have any tips or advice on how to manage or lessen the anxiety or the worry?
Thank you for this question. I feel the pain in someone who's asking this, because again, I see this quite often. The first thing to say is that the IBS needs to have been diagnosed properly, because there could be other reasons for this kind of symptom. The second thing to say is that the IBS needs to be treated. So we talked about medication, some lifestyle, treating the mind. So all of these things need to have happened to improve the diarrhea. If we've done all this and we're still getting this kind of reaction, then some of my patients are prescribed medication that helps to slow down the digestive tract, to give people a window in which they can go out with the safety, with the knowledge that they have had medication to slow down their gut. Again, this should be done with the help of a doctor rather than on your own. Another practical thing is to look for the radar key, or to request a key or a card with which you can access disabled toilets. This would take away some of the anxiety, not all of it, but I hope this would help. Another thing I tell my patients is to avoid eating right before they start on a long journey, because the gut will respond to the food. So these are hopefully a few things that might help you, but do see a doctor to get a holistic care for your IBS, rather than hoping that one or two little medication will take this away.
Thank you. My final question is gastrinoma malignant?
So gastrinoma is a tumor of gastrin-producing cells in the stomach or the duodenum. There are many varieties, but really it's outside the scope of today's talk. It's another chapter. Without looking at details of a particular case, it would be really difficult for me to give you a straightforward answer.
Thank you, Reshma. This has been very enlightening. I mean, your talk and your answers for all the questions, and we really appreciate it. Thank you.
Thank you. Thank you for having me
evening.
and listening to me. Good night.
Thank you. Good night.